Good morning, good afternoon, and welcome to all who are joining us for the mini cPIE clinic. This is the first clinic that we'll be having of a series. So if you enjoyed today's session, please feel free to come back for our future calls. This clinic is intended to be an opportunity to share country experiences using the mini cPIE tool and provide some interesting lessons learned from those mini cPIE experiments. With that in mind, we will be having presentations from countries on these calls, and we really welcome and thank our country presenters for joining us today. To get us started, we want to know a little bit more about who is on the call. I'm going to open up a poll for you to be all completing as we walk through a couple of housekeeping slides. And Cindy, over to the next slide, please. So first and foremost, I'd like to share with you all that there is interpretation available today into both French and Spanish. You can access interpretation by clicking on the icon with the circle and the lines inside that says interpretation at the bottom of your screen. When you click on interpretation, there is also the option to mute original language so that you do not get any extra audio from the English version. Next slide, please. We will be sharing the PowerPoint, the recordings, and all of the other resources after the call. As a reminder, we welcome your questions throughout the call, but ask you to please use the Q&A feature that is located at the bottom of your screen. That Q&A feature allows you to ask questions and for us to respond back to you either directly as you ask them in written form or by actually talking through some of these questions towards the end of the call. Next slide, please. With that, we welcome all folks to please go ahead and fill in the poll. And then I will show it on the screen in just another minute or two. I see we've got 64% of folks that have responded. We'll give another 60 seconds for folks to respond. Okay, and with that, I will be ending the poll in just 3, 2, 1. Okay, and we can see who we have here with us today. So we do have at this point on this call, primarily WHO folks joining, but we do have representation from Ministries of Health, UNICEF, Gavi, and others. We do have primarily global stakeholders on this call, but we do see that regional participants have joined from every region, and we welcome folks who are joining in their morning, their afternoon, their evening, and the early hours. This call is primarily composed of folks who are working in the vaccination programs and vaccine preventable space. And it is great to see that the majority of participants have heard of COVID-19 intra-action review before. So that's about 3/4 of folks have heard of the IAR. And even more folks, 76% of folks on this call have heard about the new vaccine post-introduction evaluation tool, the PIE. So with that, a big welcome to all folks for joining this call with us today. And we'll go ahead and dive into some content. Next slide, please. I'll turn over to Cindy to walk us through the purpose of our mini cPIE clinic, and then to talk with us a little bit about what mini cPIEs are.
Thank you, Shoshana. Actually, Landry may be introducing the purpose of the mini cPIE first, and I will continue. Over to you, Landry.
Thank you so much, Cindy, and thank you so much, Shoshana. Great good morning, good afternoon, and good evening to colleagues who could join us today. Maybe before I start quickly, I would like to make a quick shout out and thanks to the IVB team who have been supporting the implementation of the vaccination IARs globally, namely Shoshana, Diana, Thomas, Jenny, Karsten, and from our team, Cindy mainly, who has been leading this work from our side. So we will be having many clinics on vaccination IARs, and this one is the first. And the purpose of those clinics is to create that platform for countries where they can share their learnings and experiences in conducting vaccination IARs and how these IARs are helping them to shape their vaccine rollout at the country level. It's also provide an opportunity for countries to connect with each other in maximizing that peer learning. But most importantly, it's also an opportunity for us as WHO and also for partners who are online to identify the needs on how we can better support countries in providing the tips and also the technical support for countries that are willing to conduct IARs. So many thanks for all for joining. Over to you, Cindy, to take us through the methodology and the presentation of vaccination IAR. Thank you.
Thank you, Landry. So to the next slide. So most of you already know what an intra-action review IAR is. So I'll go through it very briefly. Basically, it's a country-owned, country-led process that brings together all the COVID-19 response stakeholders for a facilitated discussion to identify current best practices, gaps, lessons learned, so they can actually propose measures and improve the ongoing response. So in the latest version of our IAR, you can see that we have 13 proposed public health response pillars. And the 10th one is the COVID-19 vaccination. And this aligns with the WHO COVID-19 cPIE as well. And so this COVID-19 standalone IAR, we also call a mini version of the cPIE process, which seems like many of you are familiar with already. So as you can see here, this is an example country of vaccine rollout for COVID-19 vaccines. And what we are recommending right now is for countries to conduct multiple light IAR or mini cPIEs in the early phase of vaccine rollout, as you can see here in the pink. And basically this can target different program evaluation areas as the countries see the need to evaluate at that moment. And in the longer term, we're proposing to do the classic cPIE that everyone is more familiar with, a post-introduction evaluation, which is very comprehensive, very extensive, time-consuming, but it's the comprehensiveness of it is really well worth it towards the later phase of this rollout. And so as you can see here in our COVID-19 vaccination specific tools, we have 3 of these in the IAR package, and these are the trigger question database and the note-taking template, the final report template. All 3 of this are already on the WHO website and ready to be downloaded and used, and we encourage countries to customize however they wish to use this tool. Finally, I just want to share the global perspective on the mini PIE implementation situation right now. So as you can see, as of yesterday, we have 8 countries that have already conducted mini cPIE globally, and 13 countries that are actually currently conducting or planning to conduct a mini cPIE, and another 22 countries that have indicated interest in conducting a mini cPIE across all 6 WHO regions. So with this, I want to hand back to Shoshana to introduce our first speaker. So we're very fortunate to have 3 countries that have just recently conducted cPIE, mini cPIE, to share the experience with us. Over to you, Shoshana.
Thank you so much, Cindy, for that overview of the mini cPIE. We will go ahead and get started, and we will start with the Gambia presentation, and we'll return to the Bhutan presentation in just a few moments. With that, I welcome our colleague from Gambia, Dr. Sidat Fofana, to share the presentation. Dr. Fofana, over to you.
Hello.
Hello, we can hear you.
Okay.
Dr. Fofana, can you hear us?
Yes, we are trying to.
You are not able to share your screen. Let them enable you.
Yeah, I'm not able to share my screen. If you can enable me.
Dr. Fofana, if you could kindly use the slides that are on the screen, that would be perfect. If not, we can.
We are trying to share, but it's
Host disabled
participant screen sharing. Can they enable me?
Dr. Fofana, you now have access to share your slides.
Okay.
And I see that Bhutan has joined the call. So Sonam, Wangchuk, you will be after the presentation from Dr. Fofana.
Okay. All right, thank you very much. Okay, so this is the Gambia presentation on the IAR following the first 12 of government vaccination for COVID-19. This is the description of activities. Areas to be were regulatory preparedness, planning, coordination, and service delivery, funding, supply chain and waste management, human resource management and training, vaccine acceptance, demand, stock risk communication and community engagement, vaccine safety and monitoring and evaluation. Additional information, review period 5th March. We reviewed from the 5th of March to 28th June. Actually, that is the period that we are doing the vaccination against COVID-19 using AstraZeneca vaccine. The review date was from the 28th to the 29th of June 2021. And it was done through an online and on-site for 48% from WHO, UN agencies, NGOs, partners who were there, the technical and financial partners, and then vaccine product review was AstraZeneca. So this is the full activities. The NDP was developed and approved in February 2021. Then macro planning was also developed in February, the following month. Training of community health workers was done from the 28th to the 25th of May 2021. And training of canvassers. Don't forget, we also train, we give prominence to canvassers because of the hesitancy and the wild rumors that characterized the COVID vaccination program initially. And this is something that is still affecting us. And then on the 5th of March, we roll it out. And then the national launching was done at the State House involving the president, the cabinet ministers. This is done in a bit so that we are able to beat down the hesitancy and the wild rumors that were associated with the vaccine. Launching was also done at the regional level. You know, 1 week later, different regions hold their different launching ceremonies, which has helped in trying to push out the wild rumors that were going around the vaccine. Training of National AFI Committee, this was so important to us because being a new vaccine with all the good news and the bad news, because we have seen the rumors about clotting in Europe and the stoppage of the vaccination. So in order to preempt that, we try to make sure that we have some AFI committees and they were trained and in May. So regional mobilization was also done. The RCC committee went around all the regions to meet the regional officers, regional administrators, the local chiefs, the alcaldes, you know, to talk to them about the importance of this vaccine. And also road sports, where all the TV sports and panel discussions. And also we had a caravan. The caravan was definitely one of the activities that came late, but it was one of the most useful ones. Because in the Gambia, our usual mode of campaign is the NID strategy. That's we move from village to village. And then this one, unfortunately, it was not like that. And then that has brought in some serious, it has seriously affected the mode of campaign, because we were thinking that people, given the importance of the disease, people come from villages to come to vaccination centers to vaccinate. So along the way, we realized that this was not the case. People were just sitting down in their towns and their villages waiting for the vaccination team. That has forced us to change our strategy. And then we also try to put in this caravan so that it will go around from community to community. We see that has some positive impact, you know, because people were not very much okay with the information that we are giving them through the radios. But the caravan was the actual team with the vehicle going in from town to town, and then when they go try to explain to the population, and then this has definitely changed the whole scenario. People came in, but actually we realized that when this caravan reach any town, they talk, people come and try to thinking that the caravans were moving along with the vaccination teams, which was not the case. So this was a very important lesson for us. So, but definitely we end up trying to see whether we'll be able to get the teams moving with the caravan so that anywhere they are, when they talk, people will come, they will vaccinate them. So the activities, other activities, orientation was also done. Faith-based organizations, faith-based organizations were oriented in both the rural and the urban areas. Sensitization of organized groups, mothers club, the village support groups, other youth organizations were also sensitized. And we also produced some communication materials. And also the readiness assessment for the COVID-19 was going on since January. So review dates and validation of the data collection tools was also done around February. Training of installator attendants were also done, because this campaign will generate a lot of immunization waste. So the consignment of AstraZeneca we got finished around the 28th of June. So still now we are trying to get our second consignment, and then the inter-actual review came 28th to the 29th of it's a 2 days activity. So the good practices, the government good practices. Government and donor funded support for COVID-19 is a very good practice. Funding is a major activity. It's not cheap. So if wherever governments are able to put in some money and also some donor support, That's the cornerstone. National and regional institutional launching was also important. Some campaigns will do normal, one big national launching, but this one also because of the rumors against about the vaccination in Africa. No, not only Africa, but if these regions and also some of the institutions, the police, the army, and all those things, they all did their separate launching, and that has helped a lot. Adequate cold chain capacity at all levels. Gambia, we are blessed. We recently had this the Gavi cold chain support, and that has we just changed about 81 solar refrigerators with the modern ones, and we have both these cold chain, the old ones and the new ones there. So that has helped a lot. At the central level also, we have a brand new cold room, 40 cubic meter cold room, which is able to store our supply. Even if you have to get 2 hours of that, 2 hours of the supply, we thought will be in good order. If a committee is formed and trained at central and regional level, along the way also, we feel that our own training was not enough. So WHO supported us with some consultant, and they trained the AVI committees, both at the central and the regional levels. So human resources management, vaccines and supplies was also very important. Then the NDP was NDC with prioritized groups for vaccination was also available. The NVDP was there. That has helped us. The NITAG was able to give us the prioritization of our target groups. So, but the challenges centered around vaccine quality due to indemnity clause. So that has raised some eyebrows. And then some people say, if this is good vaccine, why do we have to go in forward? Do they have to ask for indemnity? So, but along the way, this has also increased the level of vaccine hesitancy, especially among the literate population. But along the way, with the various intervention, communication intervention that was highlighted before, I think had helped to minimize a bit. So financial commitment is not enough. It's never enough. It has been demonstrated by government and partners, but definitely it was not enough. So that for any country must try very much to ensure that you have enough funding for the activities. The NDP was also planned, but along the way, when the disease started to rise, and then we will find ourselves rushing, and then sometimes we did not go strictly according to the NVD plan. So we have to violate some of these things and act even before the stated dates and times. We also have this electronic reporting system, which was the tools were not enough, the machines were not enough, and that has caused some delay. And then limited coordination between national communication committees and the AIF committee. The whole COVID vaccination has nothing organized. So we want to organize this. This will happen all of a sudden. You find yourself moving towards try to address that issue. So that was also a major challenge. And the changes that triggered by the mini campaign, MOH released fund for vaccination operational cost. This was something that was triggered by the campaign. Engagement of private hospitals and state posts for COVID-19 vaccination, improved collaboration between EPI and the logistic teams. This is something that must happen, because you have a lot of sectors, and in order to succeed, these people need to cooperate so much so that they are able to move the food, because the whole vaccination program was sort of not organized at all. But EPI managed to work very well with the logistics subcommittee to ensure that our logistics are in place where needed and when it is needed. Robust engagement of stakeholders to address vaccine hesitancy. The Gambia case was very unique. I must say that all the stakeholders, the UN agencies, the Red Cross, and all, they all support the engagements of stakeholders to make sure that we address the vaccine hesitancy. It was a big problem. I know Gambia is not an isolate, but it was a big problem here. So, how can I move this thing? This one. Can you move?
Wonderful. Thank you so much, Dr. Fofana.
Yeah,
you-
wait. Hello?
Hello.
Yeah.
Would you like to conclude your presentation?
Yes. Ease of
Wonderful.
okay. Impact on COVID-19 vaccine rollout. There is implementation, ease of implementation of the national plan activity. Improve coverage of communities, as some people do not visit public hospitals for health needs. Better logistic support for vaccination activities. Improve turnout for vaccination. Improve coverage for priority groups. Improving the ongoing COVID-19 vaccine rollout. What is the number one thing you would do differently or change about the COVID-19 vaccination program going forward? The delay in releasing funds to support operational costs of vaccination. That is something that one must try to work on differently so that we are able to release the fund in time. Because sometimes when these vaccinators, they are not enumerated, they start to bring in problem, as we had all over many of the places. It was a problem. And then non-implementation of the NDP plan activities. Some of the activities are planned, but because sometimes your action is detected by what is happening on the ground. So that also is something that definitely that we do differently to make sure that we are able to do the vaccination properly. What best practice can be identified from country presentation of COVID-19 immunization, and how can this be further strengthened and instituted? Government of Gambia and partners funding, emergency funds to be set aside, and the process for assessing it be simplified. It was a very cumbersome issue for the COVID fund to be assessed, because it was managed not by Ministry of Health alone, but multiple stakeholders, and that has made it very difficult. And the institutional launchings of vaccines. Yeah, also it definitely has improved.
Wonderful. Thank you so much for that fantastic overview of Gambia's experience using the mini cPIE tool. It is wonderful to hear both what went well and where the issues occurred. And this is really the intent and purpose of these mini cPIE clinics. We will now turn to Dr. Sonam Wangchuk from Bhutan. Dr. Wangchuk, we will go to your slides. And we will hear about Bhutan's experience. Following the Bhutan presentation and the Senegal presentation, we will have opportunity for question and answer. So we ask all participants to kindly include your questions through the Q&A feature at the bottom of your screen, and we will dedicate time to answering those later in the call. Dr. Sonam Wangchuk, over to you.
Okay, thank you, Shoshana. Good evening, good morning to all our colleagues. Yeah, so okay, can I go to next slide before this slide, please? No, the following slide. Sorry, I mean, the next one. Yeah, so the mini cPIE.
Sonam, I think we lost you. Can you hear us? Sonam Wangchuk, are you able to hear us?
All relevant stakeholders by person, and participant involves are all the executives from the Ministry of Health who actually were deployed in the field to oversee the national vaccination campaign. And then we also had all the NITAG and also the member of the TAC, that is the Technical Advisory Group for COVID, to the National Task Force for the Royal Government of Bhutan, and then people who are involved in data management and collection. Basically, we have been using the Bhutan vaccine system, online system. So for those people involved in managing the online system, so they are also invited. And of course, the district health offices who actually is responsible in the field to roll out the vaccination campaign. And then of course our other supporters, development supporters, it is UAP and WHO, and of course the finance is supported from the WHO. And we actually basic planning, coordination, supply chain, safety training, media risk communication, and data recording and reporting. So if I go back to the can I go back to the previous slide, please? Yeah. So before we roll out the first dose nationwide campaign, I mean, we have been planning long time back. If you looked into our preparation phase and implementation phase, I'm not going to go through all, but you'll see that I think we have begun our preparation plan well, as early as July 2020. We had the NITAG meeting, then we actually developed the strategy guideline. Then we also looked into the cold chain assessment because we are not sure which vaccine we are going to get, whether it is ultra storage required vaccine or is -20 cold storage requirement, or is it 2 to 8 degree. So we also looked into and mapped what is our capacity and also the human resources required for carrying out the nationwide campaign. And then also the important things we realize is, since we are going to do it nationwide, that is going to be general population vaccination, we thought the conventional way of recording and reporting may not work. So this the in-house vaccine, Bhutan vaccine system. Basically, we invited some IT experts from local firms, and then we, from the Ministry of Health, we gave the inputs how the system should work. And then we had to consult with relevant stakeholders. Then of course, slowly then we started, by then we knew what are the vaccine that is going to come. Then we developed a guideline, we started training. Then slowly we started doing the communication, social mobilization about the vaccine. And then of course the AEFI management was very important, because still COVID vaccine being a new, so we are not sure what to expect really on the serious adverse events, although the manufacturer does list out the list of AFIs. And then I think finally we received the vaccines, and then before we really roll out, we also had a mock drill, but not to all the vaccination posts, but in the capital city. Then we started launched the vaccine. Then we have a mop-up campaign. So this is how I wanted to emphasize here is the planning is very important before we actually roll out the vaccination. Next slide, please. Next slide. Next slide. Yeah. So now, as of now, we have already rolled out basically that is the national campaign. I just want to actually highlight few of the key aspects of our achievement. So we actually roll out the first vaccination, first dose nationwide vaccination campaign on 27 March. That is for the period of 10 days. Of course, the vaccine we received was the donation from the government of India. Initially, we received 150,000, but that was not adequate to roll out for all the population, eligible population. So we again requested additional dosage. So we actually received by end of March around 550,000 doses. So that was actually enough for all eligible population that is 18 years and above. So it took us 10 days to do a nationwide campaign. Of course, campaign ends on 10th day, but we still the catch up, that means mop up campaign, still the people elderly and not so we call it home-based vaccination reach out. Then the important thing during the vaccination rollout here is, I mean, there was a involvement of vaccination right from the Prime Minister, because the Prime Minister was, I think, is the second person who took the first vaccination jab among the general population. So then following that, I think everybody came forward for the vaccination. And the first nationwide vaccination campaign, I think within 2 weeks, I would say, 10 days was our campaign. Then the 2-3 days was again the mop-up campaign. So we covered more than 95%, that is among eligible population, that is first dose. Then the second dose, again, only a few days back, we have completed the second dose. The same, we went by which and going ahead the campaign. For the vaccination for second dose, we roll out the Moderna, and also AstraZeneca is also available to us. So we actually provide the option to the people, because since it is the second dose, so the hectologous, the option we have provided to the people, because we have the vaccination, both AstraZeneca as well as Moderna for the second dose. And also we received the 5,000 plus dose for the COVAX. So again, for second nationwide campaign also, Prime Minister again volunteer to actually participate in the test dose. I mean, why we have to do a test dose is not that our people will not really, but to make, when you're talking of heterologous, people were really a bit confused. What is that? So we thought that at least taking a test dose among the high level people who would give a confidence in among the people to come forward to take up the heterologous vaccination. So we the second campaign was period of 1 week only. Next, please. Next slide, please. Next slide. Yeah, I missed one slide. There should be one more slide. But anyway, we have completed a nationwide vaccination, that is second dose, 2 days back only. And if you look into the coverage, you will find among the eligible population, that is 17 years and above, is 99.6%. Because after the first nationwide campaign, we didn't stop. We have continuously provided the vaccination across all the health centers for all the newly eligible population. That's why we also then provided the first dose along with second dose campaign also. That's why you will find that 99.6% is for the eligible population for all, at least the first dose. And then among those people who have taken the first dose, the second dose coverage was more than 90%. But again, we still have some certain number of people who have actually not completed the 4 weeks or 8 weeks, because if they have to take the heterologous, then they have to take, we have given the first dose and second dose interval 4 weeks. And if you go for the same vaccine, that is homologous, what they have taken the first dose, then we have given minimum 8 weeks. Because of that, I think a lot of people will still come forward after the campaign to take the vaccine. Next, please. So these are the good practices. Again, I'm not really clear what actually you really wanted in this slide. But Bhutan, since the vaccination program is very good in the country, and health infrastructure is also well distributed across all the remote places, so vaccination is a successful story in Bhutan. And also the one of the good practices that actually give us a lot of I would say advantage and confidence is last year we actually roll out the influenza vaccine for our general population. We don't want to overwhelm our hospital in case if there is a COVID outbreak, because we don't have adequate health infrastructure to hospitalize if there is a full burden. General. That's why I think we have a vaccination-wide campaign for the influenza vaccine. And also, since there was out in the country, mostly in the southern countries, so we for example do a sampling testing, also implement the measure. So same approach we have also used the rollout. You know, actually we know the where to come forward.
Sonam, unfortunately, it sounds like the connection was disrupted. Do you want to try and say that last bit again, and then kindly conclude your presentation? Dr. Wangchuk, are you able to hear us? It looks like his connection may have disrupted his connectivity. Dr. Wangchuk, are you back with us? Dr. Wangchuk, can you kindly conclude your presentation, and then we will continue on to Senegal.
Should I continue?
Yes, please. Can you kindly wrap up your presentation? That would
Yeah,
be
so we had actually during the vaccine campaign in daily debriefing, and also we invited people from the field to share the experience. And the only challenges we had is since because of the lot of restriction in the country, so we are not able to really call the health workers for the on-site training that is on physically. So it's all on virtual. So I thought that was inadequate training. The other one is because we had the vaccine system developed, again, we didn't get really time to give them hands-on training. So this was the challenges for us. Otherwise, it was fine. So next slide. And after the mini cPIE, we identified a few important best practices that we need to take forward for the second rollout. So one was we thought there was still some problem with the vaccine system. So we have to now add some else and try to do some changes, tweaking the system so that we don't face the problem during the second rollout. And the other one is the budgetary issue, because since it is of nationwide, then there was some budgetary issues. Give them a mobile voucher to to run the Bhutan vaccine system, because everything was on online. And then the other one is vaccine supply decentralization. So this was all done, and that I think we found that the second rollout was smooth. The Bhutan vaccine system was very good. We didn't have any hiccup, and budgetary also able to allocate enough budget for vaccination campaign. And also, of course, the vaccination supply we have streamlined. Next. And regarding the things that we wanted actually to share to the other countries, I think the key thing is strategize the vaccination program if you don't have adequate vaccination, because we had some experience in second dose, because initially we are worried that we may not get the adequate doses of vaccine to do a second rollout. So then we already had a strategy, risk-based, geographical, people and risk prior to how to go about, but nevertheless we could get a full dose of vaccine, so we are able to roll out. And the the practice that I would recommend is, I think, especially when you roll out a big mass vaccination, the way forward is a digital solution. Otherwise, if you do on paper writing, then it will be a nightmare for us to really collect the data, quality analyze, and see what is the coverage and how so what is the gap. So these are all good practices we would like to recommend. And of course, we realized that there was some still gap in data collections, because some of the information we are not collecting adequately to do a meaningful data analysis. So that also we have included in the system later on. And of course, other good thing was we never had the regional AFA committee instituted then. But for this COVID vaccination rollout, we also set up the regional AFA committee, and that was very helpful because we can divide our workload and we can able to follow up all the AFIs. Next slide.
And Dr. Wangchuk, I'll ask you to kindly conclude your presentation.
Sure.
So, yeah.
This is the last slide. So only important piece of advice we wanted to give from a Bhutan point of view is adopt the solution so that you can real-time data. And also the most important thing is before you roll out, I think media advocacy, risk communication is very important through your politician, community leaders, religious leaders, and others, because just posting on the website, social media is not good enough. You really have to reach out to the leaders, all influential leaders, and that is the only way I think you can reach out to the people in the community and and so then they can get convinced. The other one is the political commitment for the rolling out the vaccination. I think that is the last slide. Thank you.
Wonderful. Thank you so much, Dr. Wangchuk, for that fantastic presentation. We'll now go to the Senegal presentation from Dr. Diop. What I ask in the meantime is for Dr. Wangchuk and Dr. Fofana, can you kindly look at the questions in the Q&A feature? There are a number of questions directed to each of you. If you could kindly respond back to those questions, you can write back to them while we are doing the Senegal presentation so that we can maximize the time that we have together today.
Thank you.
Wonderful. With that, we'll go over to Dr. Diop. And we do ask, we will have to conclude exactly on the half-hour mark. We do ask you to keep your presentation tight. Over to you, Dr. Diop.
Thank you so much for the opportunity. Hello to everyone. And I'm delighted to share information with you on the mini cPIE and for this IAR against COVID. For the period which was covered for the IAR, it was from the 1st of December to the 30th of June 2021. And we held the review on the 6th to the 9th of July 2021. We had a preparatory day for that. And after the 9th of July, we finalized the report. Therefore, the format was rather mixed. We did that both online and on site. And we had 45 participants. They came from the directorates and services at the central level, but as well from medical regions, from district health centers, and we had as well community actors. So the review was held in a multi-sectoral context with health, with teaching, with university, and with territorial collectivities, as we call them. So it was excellent to have this support. We had involvement of the partner by the WHO, UNICEF, CDC, USAID, and MTAPS. The product vaccine is Sinopharm and AstraZeneca. Next slide, please. So for the preparatory phase, initially it was a national IAR. Okay. The country already experienced some vaccination before, but we had a appropriate phase of gathering documentation, which was appropriate for the rollout activities of vaccination and the data of planning for the implementation. We had program data as well and reports made on the ground, which were compiled and analyzed in order to make some corrections, for example. The agenda was consolidated and was sent to the different stakeholders. As well, the selection of session coordinators and presenters was made during the preparation day. Next slide, please. When it comes to methodology, therefore, we had plenary presentation that we made, and we had discussions with all the stakeholders concerning the core topics as well. We set up what we call thematic groups made of resource people who were relevant to all levels and from various agencies that worked well for an analysis and for intensive discussion around the trigger questions for each thematic area. We wanted to identify the various points of discussion, and they have been documented, and we generated points of action, as we call them. The thematic groups were presented their conclusions and recommendations in plenary for a wider discussion and enriching and validating the points of action. And all the results were consolidated, the recommendation and the points of action and the lesson learned were documented and shared with the relevant stakeholders. And we managed to improve the reports. Next slide, please. Now, let's talk about the areas of the ARR. First of all, I talked already about the general preparation and the coordination. We needed to deploy the vaccinations. First of all, the regulatory approval was important, then the operational readiness, then the resource mobilization and allocation, the training of health workers and volunteers. When it comes to logistics, vaccines and cold chain equipment, tools and other inputs, transportation. The last area was the quality of service delivery for the infection prevention and control measures, the monitoring and supervision, and as well the data and documentation through record keeping and data analysis. And the last areas were about communication and as well the thematics. Next slide, please. Therefore, as I said, last areas were the communication, meaning generating demand and community engagement. As well, social listening was important. And as well, to work around hesitancy or hesitation. And lastly, the last area was the vaccination safety with monitoring of the adverse reactions to the vaccine and causality assessment. Management of adverse reactions to the vaccine. Next slide, please. So here you have the key milestones of the rollout. From December 2020, we had the program through the Ministry of Health. This document was generated, and then we submitted to the PNDV, or as we call it in English, NDVP, in December 2020. And then in January 2020, there was a submission of the NDPV to COVAX, and the vaccinations came in February 2021. And in the same week, we trained the actors for the awareness campaign. And this was really strengthened in order to start the vaccination on the 23rd of February 2021. So you see overall, from December to February, we managed to gather all the documents, to submit the documents, to get the vaccination to arrive, to train the people, and then to start the vaccination. Next slide, please. Well, what were the good practices? Well, there was an inclusive coordination and planning using traditional bodies, and it was very important from the cCIE and subcommittees and the CCVS. This is the vaccination committee, the CCVS. It was a very inclusive planning, as you can see. Secondly, there was a real-time monitoring of stocks that was in the Dakar and the Diop regions, and that was done through Logistimo in a pilot project. We did very fast as possible, and we managed to remotely do a follow-up. Thirdly, a dissemination of audio and video clips on social networks through WhatsApp. That was part of the campaign, and that was really, really good. A lot of things were developed, and we tried in advance to foresee any challenges. But what were the challenges? First of all, there was a failure to strictly adhere to targeting during the first phase of vaccination. And that was a problem for all people. But for the rollouts, they were, sorry, I'm losing the sound. Secondly, a second challenge was the stockpiling of vaccines. In some regions, it was uneven between the regions about the stock area, unfortunately. And thirdly, I would say there was a lack of procedure for the free management of severe adverse reactions to the vaccine. That was a big challenge. We were lacking of procedure in place in order to have a free management that people wouldn't have to pay if there were severe adverse reactions to the vaccine. Next slide, please. Other good practices were the priority given to the vulnerable people during the first phase of the vaccination. That was nicely made.
Apologies, Dr. Diop. As we do have very limited time, I will ask you if you could kindly conclude your presentation in the next minute or two to ensure that we have a minute of time for closing.
Okay.
Sure, no problem.
Thank you.
So the priority was given to the vulnerable people. And as well, we did the monitoring of the expiry dates per batch for the deployment, for the rollout towards regions which had a high consumption. And there was an investigation of all the cases of adverse reactions to the vaccine, and especially the severe adverse cases. What were the challenges? They were insufficient when it comes to the animation of the vaccination pillar. Next slide, please. Next slide, yeah. Therefore, important actions for the rollout. It was important to hold a meeting for the Pharmacovigilance Committee concerning all the case of adverse cases against the vaccination. Secondly, to coordinate and planning inclusively by using classical bodies such as the cCIE and the subcommittees and the vaccination committees, as I said. Therefore, it was very important. There was a use of the same circuit for all the vaccination, such as Vázquez. Next slide, please. Therefore, what should we do? How can we improve the rollout? Therefore, we need to set up the right procedures for managing the severe adverse cases against the vaccination. What did we do as such practice? Number two, it was a re-rollout, which was inter and intra-regional, and that was taken it was treated by the medical regions, I must say, and that allowed us to use the vaccines according to the expiry dates, as the expiry dates were approaching. And thirdly, I would say there was an exhaustive recensing of the priority targets when it comes to the PPS. So therefore, this is what I wanted to share with you. Thank you very much.
Thank you so much, Dr. Diop, for that fantastic presentation on Senegal's experiences. It's been wonderful to hear from Gambia, Bhutan, and Senegal. We have a number of questions for our speakers in the chat. What we will do is collect those questions and we will share them with Gambia, Bhutan, and Senegal for their written response. We will then share out to all of the participants on this call a question and answer sheet that does include all of these questions and all of those responses, in addition to the presentation and links to the useful resources. In this way, you will have all of the different components that you need at your fingertips. With all of this in mind, I would like to say a huge thank you to our presenters today. Thank you for our interpreters for their fabulous interpretation into English, French, and Spanish, And a huge thanks to all of our participants who joined today for our first mini cPIE clinic. We look forward to having future mini cPIE clinics with you and learning more about other countries' experiences using this tool. With that, have a wonderful rest of your morning, afternoon, or evening, and wishing you all the best as you move forward with the rest of your week. Thank you so much and have a great day.
Thank you all. And thank you, Shoshana.
Thank you, everyone, and goodbye.